Hello, how are you doing today? This is Dr. Hamid, an ECFEMG certified physician, and today we are continuing our very high yield revision for the biochemistry chapter for the USMLE Step 1 exam. So, the carbohydrate metabolisms, either glycolysis, which is the breakdown of glucose, or gluconeogenesis under fasting conditions, where the liver and the kidney synthesize the glucose from like non-carbohydrate source, from lactate or either from glycerol or either from amino acids such as glycine, and that's gonna be like converted into pyruvate, and at the end it's gonna produce glucose to supply our body with its needs from glucose under fasting condition. So like the two processes are like going at the opposite direction. First is the glycolysis. We start by glucose. The glucose is converted into glucose 6-phosphate, and this glucose 6-phosphate is trapped inside the cells. So once the glucose is phosphorylated, it is trapped inside the cells and cannot go out. This is done by an enzyme called hexokinase, and it's one of the three irreversible enzymes. So very high yield for you to memorize these three irreversible enzymes. You don't need to like memorize all of this like the figure. You have to memorize hexokinase. This enzyme converted glucose to glucose 6-phosphate. It's a reversible enzyme, K-limiting enzyme in the glycolysis. Also, the phosphofructokinase. So the phosphofructokinase is the one that is gonna convert fructose 6-phosphate into fructose 1,6-bisphosphate. So you have to like to know that any enzyme that has kinase in its name is gonna add like phosphate group. So the glucose to glucose 6-phosphate by the hexokinase is gonna add like phosphate group, and here fructose 6-phosphate is gonna be converted into fructose 1,6-bisphosphate by another like kinase group, which kinase enzyme, which is phosphofructokinase 1. And the like the last reversible enzyme, which is the pyruvate kinase, that's gonna convert the phosphoenol pyruvate into pyruvate. So the pyruvate under aerobic condition is gonna be converted into acetyl to CoA, and like eventually into tricyclic acid cycle. And if we are under anaerobic condition, it's gonna be converted by an enzyme called the lactate dehydrogenase, and we will get lactic acid. This is like the pathophysiology behind lactic acidosis under anaerobic condition. So this is very, very important for all the body tissues, including especially the RBCs. So the RBCs has if we got condition called pyruvate kinase deficiency, we will get hemolytic anemia, because the RBCs like solely like depends mainly on this process to produce its ATP. So if pyruvate kinase deficiency leads to hemolytic anemia due to impaired ATP production in the red like blood cells. So at this enzyme pyruvate kinase deficiency malfunctioning, like we will get hemolytic anemia, and the RBCs are not gonna function well. So the glucose to glucose 6-phosphate by enzyme hexokinase, it has a negative feedback inhibition by the glucose 6-phosphate itself. Very high yield to know the glucose 6-phosphate is a like feedback inhibitor for the hexokinase, and here the feedback inhibition is through the ATP. So this enzyme phosphofructokinase 1 and the pyruvate kinase, they are both inhibited by ATP and stimulated by increase of ADP. So the ATP translates to that we have a lot of energy. So these enzymes don't need to be don't need to be active, and so the phosphofructokinase 1 and the pyruvate kinase can be have negative feedback inhibition here if we got like high ATP, and on the other hand, with the increase of ADP, they are gonna be like stimulated to act. So this is glucose to glucose 6-phosphate, and then isomerase to fructose 6-phosphate, and the phosphofructokinase. Then this is a 6-carbon like molecule. To it's gonna be transformed into like glycerolidase 3-phosphate to glycerolidase 3-phosphate, which are 3-carbon molecules. So this is a very high enzyme, glycerolidase phosphate dehydrogenase, is gonna produce NADH. So this NADH eventually is gonna be used at like to produce energy. There is very high yield to know that at this step we're gonna like get NADH. We then like low yield 2,1,2 bisphosphoglycerate, then 3-phosphoglycerate, then it's gonna be mutated by phosphoglycerate mutase to 2-phosphoglycerate, and by the enzyme enolase phosphoenol pyruvate. So you may skip this, and you have to know that we can go at the reverse direction from the pyruvate back into glucose. So this happens under fasting conditions, and this doesn't happen like in all the body tissues, but it happens in the liver and the kidney to produce like glucose under fasting condition. We will start by pyruvate and convert it to oxaloacetate by pyruvate carboxylase. We add like one carbon molecule. So pyruvate is gonna be converted into pyruvate carboxy. So pyruvate is gonna be converted into oxaloacetate by pyruvate carboxylase, and then phosphoenol pyruvate carboxylase to phosphoenol pyruvate. So this is the first like irreversible enzyme. So this is like parallel to the pyruvate kinase step. So from phosphoenol pyruvate to pyruvate through pyruvate kinase. On the other hand, from pyruvate to phosphoenol pyruvate, two steps. First, pyruvate carboxylase to oxaloacetate, and oxaloacetate to phosphoenol pyruvate by phosphoenol pyruvate carboxylase. Then these two enzymes can go both direction. So enolase, phosphoglycerate mutase, phosphoglycerate kinase, glyceraldehyde phosphate dehydrogenase, and eventually till we reach fructose 1,6-bisphosphate. So at this step we need another enzyme. So this enzyme is fructose bisphosphatase. So remember, at the glycolysis we needed the kinase enzymes to add phosphate group. So here we need like phosphatase enzymes to remove this phosphate group. So this enzyme is called the fructose 1,6-bisphosphatase, and it is gonna like break fructose 1,6-bisphosphate into fructose 6-phosphate. So it's gonna remove phosphate group, and then isomerase to convert fructose into glucose. And the last step, where the glucose is trapped into the cells, the glucose 6-phosphate, it is gonna like be converted into glucose by glucose 6-phosphatase. So this is glucose 6-phosphatase, and this is hexokinase. This is phosphofructokinase 1, and this is fructose 1,6-bisphosphatase. And remember, like the feedback inhibition for hexokinase by glucose 6-phosphate itself, and phosphofructokinase 1 and pyruvate kinase by like increase in the ATP, and the like positive feedback by increase in the ADP. So the glycolysis, it means breakdown of glucose into pyruvate, and this is gonna be either go into lactic acidose by lactate dehydrogenase, or it's gonna be converted into acetyl-CoA, and under aerobic condition it goes into tricyclic acid cycle. This occurs in the cytoplasm. So the glycolysis occurs in the cytoplasm. It's gonna produce 2 ATP, 2 NADH. There are like K enzyme. Remember the 3 irreversible enzyme hexokinase. So the hexokinase is in all tissues, while glucokinase in the liver, phosphofructokinase 1, and the pyruvate kinase. On the gluconeogenesis, on the other hand, it is gonna go the reverse direction. So it is the synthesis of glucose from non-carbohydrate precursors, so such as lactate, amino acids, and glycerol. So the lactate can be converted back into like pyruvate, and also the amino acids such as glycine. So the glycine glucose cycle. So very high yield to know that the amino acids can produce pyruvate, and eventually we've got glucose from amino acids, and also glycerol. So either like from fat, from amino acids, or from carbohydrates, we can like get our glucose to support the body under fasting conditions. This occurs in the liver and the kidney, and there are like also reversible enzymes. Pyruvate, there are two steps here. First enzyme is the two steps pyruvate carboxylase and phosphoenol pyruvate carboxykinase, and the second enzyme fructose 1,6-bisphosphatase. So we need like to break phosphate groups. Here we need to add phosphate group kinase. Here phosphatase, glucose 6-phosphatase. Also, there are reversible steps in glycolysis. Again, hexokinase, glucokinase, phosphofructokinase 1, and pyruvate kinase. These are the highest yield things to know for this topic. And the pyruvate kinase deficiency and the hemolytic anemia, because the RBCs like depend solely on this process to get its energy. If we got pyruvate kinase deficiency, so this is will stop, and the RBCs is gonna are gonna have a bad time here. So lactic acidosis occurs when the pyruvate is shunted into lactate. So this is through the enzyme lactate dehydrogenase due to impaired like aerobic metabolism through like other amino acids. So the branched chain amino acids, there are some amino acids that are branched chain, such as leucine, isoleucine, and valine. They are leucine, isoleucine, and valine. They are metabolized primarily in the muscle by an enzyme called the branched chain amino acid dehydrogenase. Whenever there's a deficiency of SHA3 enzymes, there is a very high yield condition called the maple syrup urine disease. Maple syrup urine disease. These like people affected by this, these children have vomiting, lethargy, and sweet urine odor, very characteristic sweet urine odor, vomiting, and lethargy. There are build-up of branched chain amino acid, and the branched chain amino acids are very important for protein synthesis and energy production. So the neurotransmitter synthesis, you have to know that neurotransmitters can be synthesized from proteins such as tyrosine. The tyrosine is converted into L-dopa, then dopamine, norepinephrine, and epinephrine. So you have to know that the tyrosine, dopamine, norepinephrine, and epinephrine also they have different like functions. They are connected. They have like same pathway: tyrosine, L-dopa, dopamine, norepinephrine, and then epinephrine. Next is a tryptophan converted into 5-hydroxytryptophan. So the tryptophan and the serotonin like are connected. The tryptophan is the precursor for serotonin, and also the glutamate and the GABA. So the glutamate also is a precursor for GABA. You have to know that B6 is a very important cofactor for both tryptophan conversion into serotonin and the glutamate conversion into GABA. So there are like very important like vitamins such as folate, which is vitamin B6, and cobalamin, which is vitamin B12. They are both very high yield because they are involved in rapidly divided cells. They are involved in the synthesis of the DNA. So these rapidly divided cells are affected by the deficiency of B9 and B12, like the RBCs. So the RBCs are highly like active cells that's gonna divide rapidly. So whenever we got deficiency of B9 or B12, we're gonna get megaloblastic anemia, and B12 is like specifically have like neurological consequences that doesn't happen with B9, very high yield. The difference between of them, they are also important for methylation reaction. So the methylation reaction is gonna like control the epigenetics of cells. So the methylation is gonna suppress the expression of the gene on the epigenetic level. So these are the enzymes are important also. So sorry, so these vitamins are important also for as a cofactors for like cysteine beta synthase. So there's a famous condition called homocystinuria. So they are a group of disorders affecting methionine metabolism. So normally methionine is non-essential amino acid. We're gonna get methionine from the conversion of homocysteine into methionine through the enzyme cysteine beta synthase. So the cysteine beta synthase is like very important enzymes to convert like homocysteine into methionine. So methionine is gonna be deficient. It's gonna become essential for this like people. And on the other hand, homocysteine is gonna build up. So the build up of homocysteine is very thrombogenic. So these people are gonna get thrombotic events. They will get like lens dislocation. These people have intellectual disability. So remember, intellectual disabilities. These people are gonna get lens dislocation and will get thrombotic event. Methionine will be deficient and will become essential, and homocysteine is gonna build up. This is all due to cysteine beta synthase deficiency, and these people, to treat these people, we're gonna give them like B6 and B12. So remember, B6 and B12 are like cofactors for this enzymatic process. So they gonna like cover this deficiency. So you have to give these people with cysteine beta synthase deficiency B6 and B12. So we are going to talk about the tricyclic acid cycle. So this is a very high yield for the ATP production. So the whole like process. So the whole thing behind this process is the production of ATP from ADP. So this ADP being converted into ATP on the electron transported chain. First, we're gonna start by glucose, as we have discussed, and it's gonna uh, form like pyruvate. So the pyruvate, like dehydrogenase complex, is the one that gonna convert the pyruvate into acetyl-CoA. It needs B1, B2, B3, and B5, and lipoic acid as cofactor. And the pyruvate dehydrogenase deficiency is very like high yield condition. So this is not gonna proceed, and the pyruvate is gonna build up and be converted into lactate, and we will have lactic acidosis. So this is the pyruvate dehydrogenase deficiency. Next, the acetyl-CoA is like conjugated to oxaloacetate to form citrate through citrate synthase. This is a K-regulatory enzyme. There are three K-regulatory enzymes for TCA cycles. This is the first, which is a citrate synthase. Next is the isocitrate dehydrogenase and the alpha-ketoglutarate dehydrogenase. There are three dehydrogenase enzymes: isocitrate dehydrogenase, alpha-ketoglutarate dehydrogenase, and the malate dehydrogenase. Three hydrogenase enzyme. Each one is gonna convert NAD into NADH. So eventually we will have three NADH molecules. So the isocitrate is converted into alpha-ketoglutarate through isocitrate dehydrogenase, alpha-ketoglutarate to succinyl-CoA through alpha-ketoglutarate dehydrogenase, and malate to oxaloacetate to malate dehydrogenase. These are three enzymes. Like through three NADH is gonna converted by NADH dehydrogenase. So the NADH dehydrogenase is the first first part of the electron transported chain. So the first part of the electron transported chain is the NADH dehydrogenase. Next is the succinate dehydrogenase. Succinate dehydrogenase is the one is gonna convert succinate into fumarate, but this is gonna produce Fat-H2 instead of NADH2. So this is the second part of the electron transported chain. So the first part is NADH dehydrogenase. The second part is the succinate dehydrogenase complex. So then we will have like cytochrome C, cytochrome B, and cytochrome C. So these are also parts of the electron transported chain. So the tricyclic acid cycle occurs in the inside of the mitochondria. This is needed for the build-up of hydrogen gradient. So the electron transported chain depends on the build-up of the hydrogen gradient in the intermembrane space. So this build-up is gonna go eventually into complex number 5, which is the ATP synthase complex. So it's gonna go inside from the high gradient in the intermembrane space into the matrix, and it's gonna activate the ATP synthase enzyme. So this is gonna convert ADP into ATP. And consider you have to know that complex number 4 is responsible for the transfer of electron to oxygen. So the oxygen is the electron receptor, and so these electrons from complex number 1 to going to complex number 4 is gonna eventually be transferred into oxygen. So the oxygen is the electron acceptor, and it's gonna combine with oxygen. The electron is gonna combine with oxygen to get water. So this is the behind the toxicity of cyanide toxicity. So the cyanide toxicity is gonna step at this process. There are also retinones that's gonna inhibit complex number 1. So these are they are uncoupling agent also, such as dinitrophenol. So the dinitrophenol is gonna dissipate the proton gradient. So the proton gradient normally is supposed to form ADP from ATP, but this is gonna dissipate this gradient, and instead of producing the energy, it's gonna spend this gradient to produce heat. So this is the idea behind it's being seen in brown adipose tissue, and it's gonna produce a lot of heat instead of energy that's supposed to produce ATP. So the tricyclic acid cycle, aka Krebs cycle, is our central metabolic pathway. So the acetyl-CoA we can get acetyl-CoA from amino acids, from glycerol, from glucose. So this is the final common pathway for the protein, carbohydrate, and the fat metabolism to produce energy. So it's a central metabolic pathway, and it occurs in the mitochondria. It oxidizes acetyl-CoA to CO2 and H2O. So the CO2 is produced from tricyclic acid cycle and H2O here, and it's gonna produce ATP, GTP, NADH, and the fat H2, and eventually they are transformed into a GTP. They involved in both catabolism and anabolism. So the electron transported chain and oxidative phosphorylation is a final stage for aerobic respiration. This occurs at the inner mitochondrial membrane. So this occurs again at the inner mitochondrial membrane. And the NADH and the fat H2 donate electrons to protein complex. So this is gonna donate electrons, it's gonna be transferred there, and finally it's gonna combine with oxygen to form H2O. The proton gradient here is gonna derive complex number 5 to produce ATP, and at the brown adipose tissue is gonna produce HIT instead. And also, if we got like uncoupling agents such as the dinitrophenol, also is gonna like act by the same concept, is gonna like dissipate the protein gradient, leading to heat production. So the cyanide poisoning, as we've talked, inhibits the cytochrome C oxidase, which is complex number 4, blocking electron transport and leading to rapid ATP depletion and cell death. Lactic acidosis in shock is due to impaired oxygen delivery. So either if we don't get oxygen, this is not gonna proceed. If we got cyanide toxicity, but oxygen is zero, but there is like interruption of the electron transport anyway, it's gonna interrupt the process. So anyway, it's gonna cause like anaerobic. So anyway, it's gonna affect our cells and like interrupt energy production. Next is the amino acid metabolism. So the amino acids are classified into essential amino acids and non-essential amino acids. So what we mean by essentials, it means like we must obtain them from diet. If you don't take your essential amino acid, you're gonna be get like protein malnutrition, such as marasmus and kwashiorkor. For example, leucine and lysine. The leucine is essential, is a branched chain amino acid essential for the synthesis of our amino acids and our muscles, and lysine is like very essential for like the collagen, for example. So these are essential amino acids, cannot be synthesized from scratch in your body, unlike non-essential amino acids that can be synthesized from your body. Pyruvate, for example, can be like converted into alanine, and glycine can be synthesized from serine, for example. So this is the enzyme amino acid classification. Then the catabolism of amino acid. So this like has a lot of processes. So first is transamination. So transamination, what we mean by this means like transfer of amino group into alpha keto acid. So normally this is alpha ketoglutarate, and this is through two enzyme, ALT and AST. They are like the famous liver enzyme, alanine aminotransferase and aspartate aminotransferase. Both enzymes like convert like alanine and like aspartate with like the help of alpha keto acid into glutamate if eventually. So these are aminotransferase is gonna transfer amino acids from to alpha ketoglutarate, for example, to form glutamate. So we've got glutamate here as this transamination reaction. Then like the reverse process, which is a conversion of glutamate bed into alpha like ketoglutarate. This means like deamination or the removal of amino group. So this enzyme is done through the glutamate dehydrogenase enzyme, and this leaves us with like free NH3 group, or amino like NH3 group, which is the nitrogen. So this nitrogen is excreted like as a urea via urea cycle. So first transamination, which is a transfer of nitrogen group into alpha keto acid to produce glutamate, and the glutamate then is like deaminated through the glutamate dehydrogenase enzyme with the transfer of glutamate into alpha ketoglutarate and nitrogen. So this nitrogen is excreted as urea via urea cycle, and there is a carbon skeleton left. So the carbon skeleton are eventually converted like into intermediates of glycolysis or tricyclic acid cycle. This depends on the amino acids. There are like certain amino acids that are glucogenic. For example, here you remember pyruvate, so alanine, glycine, cysteine, and serine. So these are like 4 amino acids are like glucogenic: alanine, glycine, cysteine, and serine. They are like purely glucogenic. Remember them: alanine, glycine, cysteine, and serine. So they are converted into pyruvate. And remember from our last slide, so the pyruvate is converted into like oxaloacetate and then phosphoenol pyruvate and eventually into glucose. So they gonna synthesize the glucose. So by being converted into pyruvate, they can eventually go back into glucose. So this alanine, glycine, cysteine, and serine. There are another amino acids that are ketogenic, such as lysine and leucine. They are solely converted into acetyl CoA that cannot go back and like produce glucose again. So they are trapped here. but these other enzymes, they are tryptophan. But these other amino acids such as tryptophan, tyrosine, phenylalanine, they are both ketogenic and glycogenic because they are found here, and so they can be converted into acetyl-CoA and be ketogenic, and also can be converted into pyruvate, for example, such as threonine and tryptophan, and threonine and phenylalanine be converted into fumarate. So this is glucogenic, the both glucogenic and glycogenic. You have to remember the only ketogenic, they are lysine and leucine. The only glucogenic like alanine, glycine, cysteine, and serine. So other you have also aspartate and asparagine. They are converted into oxaloacetate and they are like glucogenic. And like you memorize these other enzymes. So you memorize these other amino acids, for example, threonine and isoleucine can be converted into succinyl-CoA, the tyrosine, phenylalanine, and aspartate being converted into fumarate. So each like amino acids can be converted into certain intermediate in the tricyclic acid cycle, and you don't need to memorize them. Just memorize these like amino acids that's gonna be converted into pyruvate, and they are like purely glucogenic. Lysine and leucine, they are purely like ketogenic, and these are both, so they are like ketogenic and like glycogenic. And then the nitrogen is so then there are like disorders such as phenylketonuria and alkaptonuria. So the phenylketonuria means deficiency of phenylalanine hydroxylase. So if we get deficiency of phenylalanine hydroxylase, phenylalanine is gonna build up, and this is a neurotoxic substance. So we're gonna get intellectual disability and the seizure as a result of that. And the phenylalanine is a precursor to melanin eventually. So we got deficiency of melanin, so we'll have hypopigmentation. And the third like famous symptom is the musty body odor. This is related to the buildup of phenyl acetate. So the phenylalanine is converted into phenyl acetate, and it's gonna get musty body odor. So this is a translation of biochemical derangement into our symptoms: intellectual disability and seizures, hypopigmentation due to deficiency of melanin, and musty body odor. Alkaptonuria means deficiency of homogenetic like homogeneous state oxidase. So there is a buildup of homogeneous acids that is gonna cause darkening of connective tissue. So it's gonna give arthritis and the darkening of the body, and the another darkening of the urine also. So for the lipid metabolism, we have fatty acid metabolism that is subdivided into two processes: fatty acid synthesis and beta oxidation, which means the fatty acid breakdown. So first, the fatty acid synthesis. So this starts by acetyl-CoA that is like produced from glycolysis, and NADPH that is produced from the hexose monophosphate shunt and ATP. So we need ATP, NADPH from hexose monophosphate shunt, and acetyl-CoA from glycolysis. So this occurs under the fed states where like glycolysis we have like plenty of acetyl-CoA. So the acetyl-CoA is like in the mitochondria. It cannot go into the cytosol where the fatty acid synthesis occurs. So the fatty acid synthesis occurs in the cytoplasm. So this occurs through something called the citric acid shuttle. So the acetyl-CoA combines with oxaloacetate forming citric acid. The citric acid is gonna go out into the cytoplasm, and then it's gonna like degenerate again into oxaloacetate and acetyl-CoA. And with the enzyme acetyl-CoA carboxylase with the help of ATP, and it's gonna be converted into malonyl-CoA. So the acetyl-CoA carboxylase is a rate limiting enzyme or step here. Very high yield acetyl-CoA carboxylase is gonna convert like for malonyl-CoA. Then the like fatty acid synthase enzymes, this fatty acid synthase is gonna add two carbon atoms, like consequently two carbon atoms till we reach like finally palmitate that has like 16 carbon atoms. So after we get like our final fatty acid product is gonna combine with glycerol to form monoglyceride, triglyceride, diglyceride, and so on. So this is regarding fatty acid synthesis. On the other hand, beta oxidation. So the fatty acid is from the fatty acyl CoA. So this fatty acyl CoA cannot go to the mitochondria. So remember, fatty acid synthesis occurs at the cytoplasm. On the other hand, the beta oxidation occurs at the mitochondria. So this also we need the citrate shuttle and to get like fatty acyl CoA inside like the mitochondria, and they're like series of like breakdown of two carbon atoms, and each time we got one net each, one fat each. So every like cycle we will get one net each and one fat each. So this occurs under the fasting condition where we need energy. So this occurs under the fat condition, and on the other hand, the beta oxidation occurs under the fasting condition where we like break lipids and to get like energy. The ketogenesis is the formation of ketone bodies. There are acetoacetate, beta hydroxybutyrate, and acetones. They occur during like the lack of glucose. So either during fasting or starvation, or for example during diabetic ketoacidosis (DKA). So in diabetic ketoacidosis they are like insulin deficiency. So also the glucose is here. The body cannot use it. This is equal to the absence of glucose or the low levels of glucose during fasting or starvation. So either there's a low level of glucose during fasting or starvation, or that the glucose is here but it cannot be like used due to like insulin deficiency or insulin resistance. So here the body needs like an alternative source for the energy, and it's gonna produce like acetoacetate and they form like ketone bodies. So remember during beta oxidation there are like multiple low yield steps, but it includes the production of like acetyl CoA. So why acetyl CoA can't go on and go into like the citric acid cycle? So this is a very important question. So remember acetyl CoA can go on and go into the citric acid cycle. So if we got this is a very efficient way to produce energy. This is the main way. But here during starvation or fasting, the oxaloacetate here, the acetyl CoA, in order to enter the citric acid cycle, it needs to combine with oxaloacetate to form citrate and go into this cycle. But this oxaloacetate under fasting condition, remember from our first slide, it is oxaloacetate here. It is gonna use it to form like glucose back. So the pyruvate is gonna be converted like the to oxaloacetate, and the oxaloacetate is gonna go back to form glucose. So here we are here in fasting condition. We need glucose. So the oxaloacetate is deficient. So here the body like needs to get energy. So like this acetyl CoA is gonna eventually to be converted into these ketone bodies and as an alternative way to get energy. So it's gonna be so acetoacetate, beta hydroxybutyrate, and the acetone bodies is gonna accumulate under starvation, fasting, diabetic ketoacidosis, and the body is gonna get like lactic acidosis or diabetic ketoacidosis, and the patient may arrest on this acidosis. But this like was like the body was trying like to get energy from an alternative source, so eventually it may harm itself by like altering the pH. So the ketosis, on the other hand, means like utilization of ketone bodies for energy, like peripheral tissues, not the liver, because like the liver lacks the enzymes that is gonna like use them. So although the liver is gonna produce them, they are like utilized in the muscles and the other tissues and even the brain. So the like muscles, liver, muscles, sorry, heart and the brain, but not in the liver and not in the RBCs, because the RBCs like the mitochondria. Then the cholesterol synthesis, so the cholesterol is synthesized from acetyl CoA, and this occurs primarily in the liver, and the cholesterol is very important because like it is related to, it's incorporated in cell membrane, bile acids, and vitamin D, and steroid hormones, different sex hormones, and our steroid hormones, very high yield. And there's a very high yield enzyme which is HMG-CoA reductase that is gonna like convert HMG into mevalonate. So this is a very high yield enzyme. It is a rate limiting step here in the cholesterol synthesis, and this is a very high yield because it is the target of the statin drugs. There are very like famous group of anti-lipid drugs which are the first line, which are called the statins, atorvastatin and simvastatin and so on. They target this HMG CoA reductase, and they're gonna interrupt like cholesterol synthesis and lipid synthesis. They are cardioprotective drugs. So these are very high yield points. So remember, all major lipid metabolisms converge as acetyl CoA. So Remember, and this during like, for example, fatty acid synthesis started with acetyl CoA, and then like then here citric acid shuttle, and finally again acetyl CoA carboxylase. So it is involved in acetyl CoA, and also the beta oxidation. The fatty acids are broken down into acetyl CoA, and ketogenesis started with acetyl CoA. Cholesterol synthesis even started as style CoAs in like HMG and the MG-CoA reductase into mevalonate. So this acetyl CoA is like a central pivot for lipid metabolism, and this regulation of lipid metabolism is very central to many diseases, can lead to obesity, type 2 diabetes, and cardiovascular disease. So it is a very important factor. There is some condition called familial hypercholesterolemia. So this is an autosomal dominant condition due to LDL receptor mutation. So the LDL receptor mutation is not gonna make like LDL cholesterol. This is a bad cholesterol. There is HDL and LDL and the VLDL. So the LDL is the bad cholesterol. So with this mutation in the receptor, we're gonna get very high levels for LDL receptors and the LDL, for LDL cholesterol, and the LDL cholesterol is gonna lead to premature atherosclerosis. Some patients may get like MI at like their 20s, and they got like cardiovascular disease and obesity. So this is for familial hypercholesterolemia. So the vitamin K is essential for the synthesis of clothing factors such as 2, 7, 9, and 10, protein C and S. So it is responsible for the gamma carboxylation. This occurs in at the liver. So without this, there is this gamma carboxylation leads to activation of these clothing factors, and without vitamin K, this activation process can't go on. So we will have like bleeding. There's a vitamin K deficiency occurs with the newborns who have low gut flora that is normally synthesizing normal gut flora that is normally synthesizing vitamin K. Also, the people taking isoniazid and the people with carcinoid syndrome. So this deficiency leads to increased bleeding time and BT/INR. Next is Aplagra. So this vitamin B3 deficiency, very high yield. It has three like D's: dermatitis, diarrhea, and dementia, and finally this. So Blagra, aka niacin deficiency, 3Ds. These people have like skin condition, dermatitis, diarrhea, so and dementia. Next is a scurvy. So the scurvy is like related to vitamin C deficiency. So this is related to impairment of collagen synthesis. So vitamin C is very important for like healthy hair. So you will have corkscrew hair and like bleeding of gums and the petechiae. So it's gonna like contribute to collagen synthesis. So these people have like deficient collagen and not healthy skin. So petechiae and corkscrew hairs. So very high yield condition is Wernicke-Korsakoff syndrome. This is related to B1 cell deficiency, which is thiamine. This occurs in malnourished people, in alcoholics. So thiamine is very important, vitamin. It is a cofactor for very important enzyme, alpha ketoglutarate dehydrogenase, pyruvate dehydrogenase, transketolase. So very, very high yield enzyme. So it has like confusion, ataxia, and ophthalmoplegia, very high yield triad. These people are like disoriented, they are confused. Ataxia, if you let them walk, they will be ataxic. And they will have ophthalmoplegia, so confusion, ataxia, ophthalmoplegia. And finally, if this condition is left untreated, they are like mentally disturbed, and it's gonna lead to Korsakoff syndrome. So the Wernicke here confusion, ataxia, and ophthalmoplegia is reversible, but once we reach it into Korsakoff, it's gonna be irreversible. And rickets means vitamin K, the deficiency in the children. So these people, young people will have like vitamin D deficiency, and it has to be in their childhood to be rickets, and they are presenting with bowed legs and rachitic rosary. It means like costochondral like beating, this rachitic rosary, and this is like related to decreased calcium. So vitamin D is very important for the absorption of calcium. Night blindness is related to vitamin A deficiency, very high yield no vitamin A is related to like healthy vision. And if we got like vitamin A deficiencies, this is like gonna get early symptoms of impaired vision. So the autosomal dominant diseases, they have certain characteristics. First, the affected individuals can be heterozygote. They don't need to be homozygous, unlike autosomal recessive disease. And the males and females are equally affected. This is also like applies for autosomal recessive disease. So autosomal dominant disease, autosomal recessive diseases, the males and females are equally affected, aka not X-linked disease. The disease appears in every generation. So as long as there is mating for like all the patients in the generations, the disease is gonna appear in every generation. So this is an exception as it appear here. So the affected individuals didn't mate, but unaffected individuals do mate and they have like healthy offspring. But if the affected individuals gonna mate and they will have an offspring, so every generation will gonna be affected and the disease is gonna appear in every generation, and there is a 50 chance of passing is a trait of the offspring. So you may be heterozygous and you will be of course phenotypically like ill. So uh, let's assume that this like parent have heterozygous mutation, so there's a 50% chance of passing is a normal allele, and another 50% chance of passing is a mutant allele. So there's a 50 chance percentage chance of passing is a trait to the offspring, and there are very important terms which are variable expressivity and incomplete penetrance. So variable expressivity means like the like offsprings are affected. For example, this here is affected, but it has variable variable degree of affection, may be moderately ill, may be severely ill, may have the disease at a younger age, may have the disease at an older age, but it's gonna be affected. This is unlike incomplete penetrance, where the offspring is inherited, has inherited like the mutation and has the genetic defect, but phenotypically it is normal. This means incomplete penetrance. So the genetic defects didn't like exhibit the phenotypical disease. So this is contradicted with our rule of thumb here that the affected individuals may be heterozygous. So the being heterozygous is sufficient for you to have phenotypic disease, but there is always an exception, which is an incomplete penetrance. So there are famous examples for autosomal dominant disease. First, the achondroplasia. The mutation here is FGFR3 fibroblastic growth factor receptor 3 mutation. And very characteristic, they have limb shortening. There is like disproportionate shortening between the limbs and the torso. So the limbs are shorter than, so the limbs are shorter than the torso. So there is a disproportionate shortening for the upper and lower limbs, FGFR3 mutation, and this is the most common form of dwarfism. Next is the Marfan syndrome, the fibrillin 1 mutation, FPN1 gene mutation, fibrillin 1 mutation. The hallmark about it is like weakening of the connective tissue. So this translates into different clinical symptoms. So lens dislocation, there is a weakening of the connective tissue like that is holding the lens in its place, and there is lens dislocation, also weakening of the connective tissue of the aorta. There is aortic aneurysms, and there is of course a tall stature. So Marfan people are have tall stature, archanodactyli. So this means like elongation of toes and fingers. So this elongation of body parts plus weakening of connective tissue, lens dislocation, and aortic aneurysm. So Huntington disease, there is a trinucleotide repeat expansion, CAG, cytosine, adenine, and guanine, trinucleotide repeat expansion. There is very important term here, which is anticipation. This means like with every generation, there is earlier onset of maybe an earlier onset of the symptoms or like more severe disease. So with an anticipation, the means me like more severe disease with every successive generation and accumulation of this like trinucleotide repeats. So it's gonna be more repeats, more trinucleotide repeats, and this is translated to more severe symptoms, earlier onset of symptoms. So the hallmark about Huntington disease is dementia. So it is it is under the classification of dementia. But if you find a patient that has like dementia and they is like 40, for example, has younger age, you have to think about Huntington disease, and it has like also psychiatric symptoms. So like the constellation of dementia, plus psychiatric symptoms, and the plus chorea, which means involuntary body movements, means like most probably it's Huntington disease, and you have to think about it. Familial hypercholesterolemia, we've talked about it as a lipid metabolism revision. So LDL receptor mutation. So LDL cholesterol is a bad cholesterol, and it is supposed to be sucked up by LDL receptor from the blood. And if we got mutation at this LDL receptor, we're gonna get elevated LDL, and this is a bad cholesterol. Remember, so these patients are gonna get a premature coronary artery disease. Very high yield to know that these patients may get premature coronary artery disease at their 20s, 30s, for example. And they, like externally, they may have like tendons and somas, which are like lipid accumulations as the tendons under the skin. So tendons and somas, premature coronary artery disease, familial hypercholesterolemia, neurofibromatosis type 1. So this is an F1 mutation. They will have cafe au lait spots. You have to know that cafe au lait spots are dark spots, unlike ash leaf spots, which are pale spots. So from their name, they are cafe. Remember, the cafe is dark. So the cafe au lait spots are the ones associated with neurofibromatosis type 1. And also from its name, neurofibromas, they are like benign tumors that occur along the nerves. So neurofibromatosis, of course, are gonna have like neurofibromas. Also, cafe au lait spots, lysis nodules in the eyes, iris, aka iris hamartomas, and axillary freckling. So these are very high yield, like these accompanying like tumors associated with neurofibromatosis type 1. Next, autosomal dominant polycystic kidney disease. There is a defect as the polycystic kidney disease 1 and polycystic kidney disease 2 genes. Mutation. It is an autosomal dominant, of course. So from its name, autosomal dominant polycystic kidney disease, there are multiple cysts in the kidney, but it's not like just like that. They have also multiple cysts in the liver and in the brain, aka perianeurysm. So bilateral renal cysts, liver cysts, and perianeurysms, and these people are gonna get are going to get like progressive renal failure, so they may have renal failure at a younger age. So this is for autosomal dominant polycystic kidney disease. So next is the autosomal recessive next is the are the autosomal recessive diseases. So there are also certain characteristics for them. So the affected individuals here need to be homozygous, because being heterozygous isn't sufficient to have be like phenotypic disease. So next is the males, and the males are equally affected. Again, this is not an X-linked disease. The disease often skips a generation. They are horizontal pattern in the pedigree. What does this mean? So remember, so this as affected individual 100% must have a parent that has the disease. So for the like affected individuals to have the disease, 100% that his parent, one of his parent has the disease. But here it is not the case. So for example, this maybe there's an affected individuals like here, and both of parents don't have the disease, and you may ask, where did I got the disease? Because the alleles were here, but they were dormant. So like often skips generation, and the parents don't need to be diseased for an individual to have the disease. There is an increased risk of autosomal recessive disease with consanguinity. So the related parents' marriage is gonna increase like the autosomal recessive diseases. They mostly consist of enzymatic defects. So unlike the autosomal dominant diseases, where they have like structural defect, achondroplasia, structural protein defects, achondroplasia, Marfan syndrome, Huntington disease, here the most of these diseases are like related to enzyme defects. Very high yield to know that if you are asked about it in the exam and you find that disease is related to enzymatic defects, you may guess it is an autosomal recessive disease, such as phenylketonuria, phenyl hydroxylase deficiency. Also, so cystic fibrosis, we're gonna talk about it. We are going to talk about it in the next slide. Phenylketonuria is related to phenylalanine hydroxylase deficiency. So these people will have built up of phenylalanine, and this phenylalanine is neurotoxic. So these people are gonna get intellectual disability and seizure. This build up of phenylalanine translates into clinical symptoms, intellectual disability, and also like seizures. and fair skin because phenylalanine is like in the pathway of the formation of the melanin. So the melanin is interrupted here at this phenylketonuria patient will have fair skin. Also musty body odor, very famous because the phenylalanine it accumulates and it translates into transforms into phenyl acetate. So it has musty body odor. So musty body odor, fair skin due to melanin like deficiency and build-up of phenylalanine, neurotoxic substance, intellectual disability, and seizure. Sickle cell disease is due to like hemoglobin, beta globulin chain mutations. Is hemolytic anemia, and these people will have vaso-occlusive crises and autosplenectomy. So the autosplenectomy is related to splenic infarction, multiple splenic infarction at younger age. It, like accumulates, and this spleen is gonna be like vanished, and these people will have autosplenectomy, and this translates it to increased risk of infections. These people will have infection, and they need to have like antibiotic prophylaxis, and they also will have vaso-occlusive crises. Wilson disease, ATP7B mutation, very high yield to know that this relate to cover accumulation. So the cover is not gonna be excreted into the bile efficiently, and it's gonna be accumulate, and you have to know where it is gonna hit. Very high yield to know if as long as it accumulates, where it is gonna be like heading, which different body parts. First is the liver. So the liver, you will have liver disease. Also at the eye, so you'll have Kaiser-Fleischer rings, and into the brain, so you will have like tremors and neuropsychiatric symptoms. So Wilson disease patients will have cover accumulation in the liver, aka liver diseases, in the eyes, Kaiser-Fleischer rings, in the brain, neuropsychiatric symptoms, tremors, and psychiatric symptoms. This is unlike hemochromatosis. There is an HFE mutation, and the iron also is gonna be overloaded. So, but it's gonna be heading toward different parts. So, it's gonna be heading towards like accumulates in the liver as like Wilson disease. So these people are gonna get cirrhosis, but it's gonna accumulate at the pancreas. These people will have like diabetes and the skin bronze skin and the heart cardiomyopathy. So the hemochromatosis patients are gonna get cardiomyopathy, cirrhosis, diabetes, like bronze skin. But Wilson disease patients will have also liver disease, but they will also have like Kaiser-Fleischer rings and neuropsychiatric symptoms. You have to like memorize the difference between them, not to get be confused as the exam. Next is the thalassemia. This is the defective globulin synthesis, either beta or alpha, whatever. These people will have microcytic anemia and ineffective erythropoiesis, and the body will respond to this by having hepatosplenomegaly as a way to correct this anemia. So there also multiple transfusion, and there is iron overload. So this is also very dangerous for the body, iron overload due to multiple transfusions, hepatosplenomegaly as a way of trying to correct the anemia, and the microcytic anemia, also ineffective erythropoiesis. Then a very high yield disease that is highly tested on the USMLE, which is cystic fibrosis. So it's guaranteed that you're gonna get one or more questions in your exam about cystic fibrosis. So it is an autosomal recessive disorder. So there is a defect in CFTR gene. So cystic fibrosis transmembrane conductance regulator gene. So this is CFTR gene on chromosome number 7. So the most common mutation is the deletion of phenylalanine at the position 508. So this relates to like misfolded protein. So this most misfolded protein won't reach the cell surface to do its job. So it's supposed to this CFTR proteins is a channel that is supposed to be on the cell surface to do its job. So if we got the deletion of phenylalanine at the position 508, misfolded protein, and no healthy CFTR. So the CFTR encodes for an ATP gated chloride channel. So this CFTR or like gated like chloride channels will be absent from the cell surface and won't do its job. So this is a very confusing point. You have to know the job of CFT of like this ATP gated chloride channel is different from the normal cells to the sweat glands. So in normal cells, it's supposed to has as it here is gonna supposed to secrete chloride and water to the outside into the mucus, for example, from inside the cells to the outside where's the mucus layer, and it's gonna supposed to regulate the sodium channel. So let's assume there is absent this ATP gated chloride channels, so the chloride won't be secreted and the mucus is gonna be sick, and the so there is ENAC, so this is a sodium channel, is supposed to be regulated by also by this ATP gated chloride channel. So this is gonna lose this regulation, and the sodium is gonna be absorbed. And the sodium rule, remember, it is osmotically active. It's gonna absorb water and make the mucus less viscous. But here it is lost its regulation, and the sodium is absorbed into inside of the cells, and consequently the mucus layer will be very viscous because of two factors. First is the loss of secretion of chloride due to the defect of this ATP gated chloride channel, and secondly the loss of regulation of the ENaC and the more absorption of the sodium. So this is different from the sweat gland. The sweat gland exactly the opposite happens. So this CFTR mutation is supposed not to secrete chloride, but it's supposed to absorb it. So if it's gonna supposed to be absorbed and it is malfunctioning, it's gonna accumulate at the outside. This is the idea behind the increased chloride concentration in bilocarbine induced sweat test. If it is more than 60, it's confirmatory for cystic fibrosis. And for the newborns, we need another test, which is increased immunoreactive trypsinogen. So for adults, we may do bilocarbine induced sweat test, and we find increased chloride concentration more than 60. In the newborns, we have a screening test here, which is increase in immunoreactive trypsinogen, and the confirmatory test, which is the genetic testing for the mutation itself, CFTR mutation. So this is for the cystic fibrosis pathophysiology, and the clinical manifestations is different according to the system. So the whole idea behind it is a sick secretion, either sick mucus, sick pancreatic secretion, GI gastrointestinal secretion. So by having a sick pulmonary secretions, so we're gonna have recurrent infection. Very high yield to memorizes the exact organisms that are responsible for infection in cystic fibrosis, which are Staph aureus and Pseudomonas aeruginosa. Again, Staph aureus, Pseudomonas aeruginosa, very high yield to know that. And these people may have bronchiectasis, and the hallmark of bronchiectasis is recurrent infection and the dilatation of the airway. Next is a GI affection. So there is a also secretion at the pancreas. This is gonna clog the pancreatic ducts, and we will have pancreatic insufficiency, and consequently the pancreatic juice won't reach the small intestine, and we will have malabsorption, and even in the newborns they may have meconium areas. And the people will have deficiency of fat-soluble vitamins A, D, and E, and K. So this is for GI effects. Next is reproductive effects. So it is different between male and female. For the females, also the same pathophysiology. There is a thick cervical mucus, so it is gonna hinder the sperms. So these females will have subfertility versus the males. They have another pathophysiology, which is absence of vas difference. So they will have total infertility. Consequently, they will have total infertility. So there is absence of vas difference in males versus subfertility due to thick cervical mucus as the females. These people may have nasal polyps, sinusitis, clubbing from hypoxia, and recurrent infections, and bronchiectasis itself will cause clubbing, biliary cirrhosis. So this is are the clinical manifestations for cystic fibrosis. That's a treatment. So we will have to treat these different symptoms. First, we will act as a CFTR mutation itself. We give modulators. They are ivacaftor, lumacaftor, tizacaftor. Very high yield to know that they are cystic fibrosis transmembrane conduction regulator modulators. So these are CFTR modulator, ivacaftor, lumacaftor, and so on. Next, we're gonna work as the mucus itself. There is a sick mucus, so we may give inhalation of hypertonic saline. So this hypertonic saline is gonna draw water and make it less viscous. Also may give like something that's gonna break it down, DNAs, dornase alpha, dornase alpha, hypertonic saline, and schistophysiotherapy. We may need to give antibiotics for acute exacerbation and even a prophylaxis. And also pancreatic enzymes are needed because there's a pancreatic insufficiency. Next, we're gonna move fast through this disease because we're gonna talk about it in details later. So glucose 6-phosphate dehydrogenase deficiency, these people will have hemolytic anemia. They are like triggered by certain like oxidative stress because the RBCs here can't fight this stress due to like G6PD enzyme deficiency, drugs, fava beans, and the infections may transmit acute attacks of G6PD. Next, Fabry disease, like this is another storage disease. The hallmark is a deficiency of alpha galactosidase. You have to memorize alpha galactosidase is the one that goes with Fabry disease. These people may have angiokeratomas, renal failure, and there is a paresthesia, like peripheral paresthesia in the acroparesthesia in the peripheral limbs. This is Nyhan syndrome. So this is the enzyme deficiency, HGBRT, hypoglycemia, phosphorylated transferase deficiency. These people have hyperuricemia, self-mutilation, and chorioacetosis. So very high yield to know the self-mutilation. And ornithine transcarbamylase deficiency, people will have hyperammonia, protein. So Lichtenstein syndrome, HGBRT deficiency. So this is the enzymatic deficiency here. These people will have hyperuricemia, choreoacetosis, and the very, very famous that this to know that very, very high yield to know that these people have like self-mutilation. So self-mutilation along with hyperuricemia and Lichtenstein syndrome versus ornithine transcarbamylase deficiency, they have hyperammonia and the protein intolerance, and they also have like neurological symptoms. So X-linked recessive diseases, this is another whole story. So they also have characteristics. First, the males are primarily affected. So the males are having XY versus the female having XX. So remember, this is X-linked. So it's exclusively present at the X chromosome. So the males have X and Y. They don't have another X. So if we got one affected allele, we got the condition. So this is why the males are primarily affected. They are hemizygous. Females are typically carriers. So typically the females, if the females have got like one diseased allele, they have a compensatory one, normal one, another X chromosome. So they are typically carriers. Next is there is no male-to-male transmission. Remember, the father's contribution to its son is Y chromosome. And as long as chromosome won't ever like carry this X-linked recessive disease, so the male will never pass this disease to its sons, but is gonna pass it to all of its daughters, versus the female that is gonna pass it to daughters and sons at 50-50 chance, because the female, if it is carrier, so it is more like the autosomal dominant concept. So 50 chance passing the mutant allele, 50% chance of passing like the normal allele. Next, you have to know that there's something, a concept called X inactivation, aka lionization. So this is some random inactivation of X chromosome in all of the cells for XX individuals, and you have to stress on the random word. So it is a random process. So this occurs in the embryonic development and is maintained in all cell lineage. And so as long as it is random, so there's not a problem. But if there's some skewed activation that is a specific, like X chromosome is affected, so in all of the cells, and if this is inactivated specifically in all of the cells, and the other X chromosome is the one with the mutant allele. So I think here we've got a picture more like the XY chromosome in the males. So the X chromosome that's supposed to be compensatory is now specifically inactivated and is specifically targeted, not a random process. Some cells will have it and some others will compensate for that, but it's like directed in all of the cells. And the other X chromosome is the one who've got like the diseased allele. He is the one who've got like the X-linked recessive disease. So here is the problem. So also the females with Turner syndromes are more likely to have X-linked recessive disorders, of course, because they have X0. So they are more like males. So if you got this X chromosome is the one with a diseased allele, so of course, they will get this X-linked recessive disease. So there are some diseases which have this way of inheritance, the Duchenne Becker muscular dystrophy and hemophilia A and B. So Duchenne muscular dystrophy versus Becker muscular dystrophy. So the inheritance of Duchenne muscular dystrophy is the X-linked recessive, and also Becker muscular dystrophy, because both of them are like examples for X-linked recessive inheritance. Very highly to know that concept of frame shift and the nonsense we have talked about this earlier. So the frame shift deletion means the deletion of codons not divisible by 3. So each 3 codons code for a specific amino acid. If we deleted a number not divisible by 3, is gonna miss all the consequent sequence of amino acid, and we will have totally different protein, and is gonna cause multiple catastrophic effects. This is a frame shift. Also, nonsense mutation. Some forms of Duchenne muscular dystrophy are due to nonsense mutation. Nonsense mutation is gonna produce a stop codon UGA, UGA, UAG, and so on. So this is a stop codon. It's gonna code for a stop to stop the protein, and this is a truncated protein. So either frame shift or nonsense, both of them will have catastrophic effects. So the dystrophin is either absent or truncated, and this is a very dangerous problem, condition. And the people age of affection is less than 5 years. They will have rapid progression, and they gonna be wheelchaired by less or more or less 12 year age. 12 year of age, and they will have life expectancy of 20 to 30 years old. This is a very bad problem. So Duchenne muscular dystrophy, X-linked recessive disorders, is a frame shift deletion or nonsense mutations in dystrophin gene. This results in either truncated or absent dystrophin protein. And the dystrophin normally anchors muscle fibers to the extracellular matrix. The age of onset, as we've talked before, age of 5, there is a progressive muscle weakness. This, it begins as a pelvic girdle, and this is why Gower sign. This is the why behind Gower sign. So they have pseudo hypertrophy of the calf muscles. So the calf muscles are weak, and so if these young people begin to stand up, they can't depend on these calf muscles, and they depend on their arms. So Gower signs means the usage of arms to stand up due to fibrofatty replacement or pseudo hypertrophy of the calf muscles. There is a waddling gait and lordosis, and the very highly to know that the most common cause of this is dilated cardiomyopathy. These people have dilated cardiomyopathy. So a rule of thumb, most of the diseases that have dilated cardiomyopathy, when you are asked about the cause of this, it's probably related to the heart. So here's the dilated cardiomyopathy is the cause of this. And the diagnosis increase CK, creatine kinase, and aldolase, and of course the genetic testing is a confirmatory test. This is for Duchenne muscular dystrophy, and the Becker muscular dystrophy is also a X-linked recessive. So this is non-frame shift, so it is much milder. So for Becker muscular dystrophy is also X-linked recessive. This is a non-frame shift, so it is much milder. This doesn't involve the loss of three codons not divisible by 3. So it is not gonna have some catastrophic events like Duchenne. This is a partially functioning dystrophin. So the age of onset is adolescent and adult, not like Duchenne, where it onsets before 5 years. There is a slow progression, and variable age for a wheelchair, but not like Duchenne, where they will be wheelchaired by 12 years age. These people will have much more longer life expectancy. They may live into their 40s or 50s. So this is for Becker's muscular dystrophy. And next there's a myotonic dystrophy and mitochondrial disease. So the myotonic dystrophies are, on the other hand, they are autosomal dominant disorders. There's also, as a Huntington disease, there are trinucleotide repeat expansion in a gene called the DMPK gene. So myotonic dystrophy, and the gene is called the DMPK gene. The trinucleotide repeat expansion is CTG, cytosine, thymine, and guanine. So they have clinical picture. There's aminomix related to the expansion CTG. So C is cataracts, T is Tourette, which is early balding in males, G is a gonadal dystrophy, atrophy. So there's atrophy of the gonads, Tourette, early balding, and the cataracts. And very high yield, very high yield to know that, because they have myotonia. So, like there's a difficulty of releasing hand grip. So this is a keyword, very high yield keyword when you are like doing a USMLE question. So you gonna if you look for difficulty of releasing hand shake, difficulty releasing hand grip, and they have muscle wasting and cardiac arrhythmia. So the muscle biopsy shows ring fibers and central nuclei. The age of onset typically 20 to 30 years of age. So you have to remember two things. First is the difficulty of releasing hand grip or the myotonia. Next is the clinical feature, which are cataracts, toupee, and gonadal atrophy. This is in the mnemonic CTG, which is the same repeat trinucleotide repeat expansion CTG. And the mitochondrial diseases next. So the mitochondrial diseases, they are disorders arising from failure of oxidative phosphorylation. So you have to know that the mitochondria is the energy like factory for our body. So this is related to acetyl-CoA. So that first we start by glycolysis given by robasin, being transported into the mitochondria into acetyl-CoA and the tricyclic acid cycle, and finally oxidative phosphorylation and electron transported chain. Also beta oxidation for fatty acids. There is a fatty acyl-CoA transporters. They're gonna transport fatty acyl-CoA into beta oxidation, and finally also into acetyl-CoA. So if all of this is interrupted here, we will have like very, very huge problems with specifically with the high energy requiring organs. So such as CNS, skeletal muscles, they are high energy requiring organs, so you're gonna be affected badly. Next, you have to there's maternal inheritance pattern here. So the mothers will pass these conditions to both sons and daughters, and the males may be affected but will not like pass these conditions because the mitochondrial inheritance is a maternal inheritance form, so very high yield. So there is some concept here, it's called the heteroplasmy, which is a mixture of normal and mutant mitochondria in the cells. So not all mitochondria need to be like diseased. So we've got three examples here: MELAS and MERV and liver hereditary optic neuropathy. So MELAS, all of them will have ragged red fibers muscles on biopsy, ragged red fibers muscle on the biopsy. So this refers to like abnormal mitochondria, malfunctioning mitochondria under microscope, where they will have ragged red fibers like appearance under microscope, and there is something specific for each like condition, and this is from its name. So MELAS ME, mitochondrial encephalomyopathy. So this refers to strokes episodes. So strokes like episodes before the age of 40, seizures, dementia. So this like encephalomyopathy. So this refers to the defect with the brain. So MELAS related. So some has brain damage. Stroke-like episodes before age of 40, seizures, dementia. Lactic acidosis, this ME, mitochondrial encephalomyopathy, LA, lactic acidosis, and S, stroke-like episodes, and of course the ragged red fibers. So this is the way to memorize it. MIRF also will have ragged red fibers, but from its name, myoclonic epilepsy. So you have myoclonus and epilepsy, ataxia, and progressive dementia. So this is remember, progressive dementia is like here and here because the CNS is a highly energy requiring like organ, and there is a dysfunction with the mitochondria, and the brain is gonna be affected. Finally, liver hereditary optic like neuropathy. This is a defect in the and mutation in the complex number one of the electrotransporter chain. So remember, electrotransporter chain is inside the mitochondria, and the complex number one is the NADH dehydrogenase. So this is the complex number one. There is a mutation in it. There is a subacute bilateral vision loss. So the males are more than females affected. Here, this very high. Like you have to notice that, and they may have like neurological dysfunction also. So all of them may have neurological dysfunction, and you have to memorize that the area of defect here for hereditary optic neuropathy, which is complex number one of the electrotransporter chain. So the Fragile X syndrome. So this is the most common disease that is causing intellectual disability. This is the most common, again, inherited. Sorry. So Fragile X syndrome. So this is the most common inherited cause of intellectual disability. Very high. You did to know that. So it is pretty common cause. So Fragile X syndrome, so it is the most common cause, inherited cause of intellectual disability. Most common inherited cause of intellectual disability, again, is a Fragile X syndrome. So it follows also X-linked inheritance, but it is follows X-linked atypical inheritance, because here the females can be affected and their level of affection is usually milder, in a milder form. So this is why it is atypical. It's still X-linked but atypical inheritance, where the females are also commonly affected but at a milder forms or not affected. So this is CGG, trinucleotide repeat expansion. So it is a trinucleotide repeat expansion disease. The level here CGG. So CGG was Fragile X syndrome, and the gene is FMR, gene familial mental retardation 1 gene, and there is a hypermethylation of cytosine residues and a decreased gene expression. So remember, hypermethylation at the level of the epigenetic level is gonna cause like gene suppression, and this is the most common inherited cause again of intellectual disability. Repeat expansion, of course, CGG, and there is aminomig from the CGG. There is a C chain. These people, these intellectually disabled people, will have like a protruding jaw. First, protruding jaw. Secondly, when they after puberty, they will have giant testes, very characteristic. So you will look for this like things in the vignette. So if the patient is having mental retardation plus protruding jaw, or like general features is a long face, large everted ear. So the different kind of weird features such as long face, large everted ear, autism, protruding jaw, and giant testes, which aka microorganism. After puberty, you have to suspect that these people have Fragile X syndrome. They may have mitral valve prolapse and hypermobile joints and self-mutilation. So you remember, self-mutilation occurs with Lesch-Nyhan syndrome. So Lesch-Nyhan syndrome and Fragile X syndrome both have like self-mutilation, and there are other characteristics for Fragile X people. They have long face, protruding jaw, large everted ears, plus after puberty they may have giant testes. So there is something called the pre-mutation and the full mutation. So the pre-mutation level is from 50 to 200 repeats. So these people may have just tremors, ataxia, and if she is female, she may have primary ovarian insufficiency, versus full mutations that have like the whole clinical picture as here. It needs like more than 200 repeats. So it follows genetic anticipation. So again, genetic anticipation, either disease severity increases in successive generation, or the age of onset decreases in successive generation due to expansion of unstable trinucleotide repeats during gametogenesis. So this is a common feature of trinucleotide repeat disorders. So this is about trinucleotide repeats. So to recap, trinucleotide repeat disorders, first is Huntington disease. Remember, the Huntington disease was under the classification of dementia, and it has like psychiatric symptoms along with it and the chorea. So this occurs due to defects at the caudate level. So there is a caudate atrophy, and there is a style decrease in acetylcholine and the GABA. So remember, Huntington disease was under the classification of autosomal dominant disease. Myotonic dystrophy also was autosomal dominant disease, and instead of CAG, such as Huntington, it has CTG. So CTG, cataract, Tourette, which is male balding and gonadal atrophy. This is myotonic dystrophy. And Fragile X syndrome, as we've talked in our last slide, is X-linked disease. So there has protruding chin, like long faces, everted ears, and giant gonads, plus mitral valve prolapse, of course, and self-mutilation. And Friedreich's ataxia, lastly, GAA. This is an X-linked recessive. So Friedreich's ataxia, from its name, it has ataxia gait and cardiomyopathy and diabetes. So ataxic gait plus cardiomyopathy and diabetes, GAA level, like trinucleotide repeat expansion, Friedreich's ataxia. So next is the autosomal trisomy. So there are some general concepts. So the autosomal trisomies are screened in the first and second trimester, and the incidence Down syndrome first, next Edward, and next is Batau. So Down syndrome has more favorable diagnosis, like prognosis. Then Edward syndrome, then Batau syndrome is like the same consequence as their level of incidence, and the autosomal monosomies are incompatible with life. So we have like two chromosomes. they may be expanded to be 3 chromosomes. So this is what we mean by trisomy. But if we lost 1 chromosome and we have 1 chromosome, it is called the monosomies. But monosomies are incompatible with life versus trisomies. The most cases are due to meiotic non-disjunction. 95% of cases are due to meiotic non-disjunction. They increase with advanced maternal age. 4% only is due to unbalanced Robertsonian translocation between 14 and 12, for example. So we're gonna talk about it. And one occurs due to post-fertilization, mitotic errors, mosaicism. So some cells will have like trisomies and others may not have, depending at the level of the gametes and the prognosis of the zygotes, where the level. So this is depending on the level where the mosaicism occur at the zygote. So the screening markers vary by the trisomy type, as we've talked here. So as a rule of thumb, beta HCG and BAPPE, which is plasma associated pregnancy associated plasma protein A, they are decreased in all of them, except here is the first trimester for Down syndrome. There is an increase in the beta HCG, and the BABB is decreased also. And the chromosome error trisomy for Down syndrome is 21, 18 for Edwards syndrome, and 13 for Batau syndrome. From the most for the highest incidence to the lowest, Edward Down, then Edward, then Batau. But the survival is different. Down syndrome, 60 to 70% remarkably survive to age of 60, very high yield. But Edward and Batau syndrome mostly die by age of 1. You have to know some key features to recognize them in the vignettes. So the Down syndrome patients have flat faces and epicancer folds above the cancer of the eye. And if you look at their palms, they will have single palmar crease and brush field spots in their eyes. Of course, they will have intellectual disability, and they have cardiac defect, atrioventricular septal defect, and early onset Alzheimer's. So at the level of their brains, they will have intellectual disability and early onset Alzheimer's, and another features to recognize them, such as flat faces, epicancer fold, single palmar crease. Versus Edwards syndrome, they will have more grave symptoms and structural abnormalities such as prominent occiput, rocker bottom feet, and also of course intellectual disability, low set ears, and clenched fists. And finally, Batau, the worst prognosis and the worst condition. So severe intellectual disability here, not intellectual disability, but severe intellectual disability. They will have hollow brachycephaly, the brain, two hemispheres are not separated, hollow brachycephaly, and the small eyes, microphthalmia, cleft lip, and palate. So all of the anomalies at the level of the head, hollow brachycephaly at the brain, microphthalmia at the eyes, cleft lip and palate, and polydactyly, multiple fingers, and the congenital heart disease, of course. So the chromosomal disorders, remember, Robertsonian translocation was responsible for 4% of the cases of Down syndrome. So what we mean by Robertsonian translocation, so this doesn't occur at any chromosome. It occurs at 13, 14, 15, 21, and 22. So 13, 14, 21, and 22, and 50. So these chromosomes are special because they are have long arms and short arms. The short arms contain some redundant rRNA. So if we got translocation, we will have one chromosome that have the two long arms. So this is long arm, and this is another long arm. So this is the chromosome that that is having both long arms. And there is something called balanced carriers and unbalanced carriers. So the balanced carriers are phenotypically normal, but if these cells that have Robertsian translocation have gone into meiosis, and they may produce unbalanced carriers. So one cells may have one gamete may have this chromosome that is having the whole material, the whole important material, and the other is having the short arms that are containing redundant rRNA. So if we got a gamete that containing redundant RNA, so it is this is going to be unbalanced carrier. This occurs as a level of Down syndrome between 14 and 21, and Batau syndrome between 13 and 14. So again, Batau syndrome 13, so the 14 is a cofactor. So for 14 and 21 is Down syndrome. 14 and 13, so Batau syndrome, remember, they have 13 anomaly at the level of chromosome number 13 and Down syndrome at the level of the chromosome 21. So 14, 21, 13, 14. Important because of familial Down syndrome, not related to maternal age. Remember, meiotic non-disjunction occurs more in advanced maternal age, but this is not related to the age. They are like 4% of the cases, but they are not related to age. Next is alloy yield disease. It's called the Cry-Ducat syndrome. It is a deletion on the short arm of chromosome number 5. So they have like 46 chromosome, but there is a deletion at the short arm of the chromosome number 5. So it means literally cry of the cat in French. So these people will have intellectual disability and the cry of the cat, which is high-pitched cat-like. Ventricular septal defects, severe microcephaly, very small head, and distinctive facial features such as apicanthal folds. Then next, also Williams syndrome. There is a microdeletion of the long arm of chromosome 7. So Cry-Ducat and Williams syndrome includes some sort of microdeletion. So the Williams syndrome, the people have extreme friendliness with strangers. So they are famous for being extremely friendly with strangers, and they will have well-developed very verbal skills, but they have like characteristic elephant features, such as if you look at their like face, they will have broad forehead, short nose, and full cheeks. Also hypercalcemia. So to memorize, you have to memorize these chromosomes and the associated disorders. So at the level of chromosome number 3, there is von Hippel-Lindau disease and renal cell carcinoma 4. So the group for chromosome number 4 includes the autosomal dominant disease we have talked about, Huntington disease, achondroplasia, autosomal dominant polycystic kidney disease. For 7, remember here Williams syndrome and cystic fibrosis at 7. Also Williams syndrome is also at 11, and MIN1 syndrome and beta globulin defects. 13, remember, but that was 13 chromosome, and Wilson disease, BRCA2 and retinoblastoma, and 22, so neurofibromatosis number 2, and the Dye-George syndrome, 22Q and Q11. So next, the fat-soluble vitamins, they are A, D, E, and K. So there are general characteristics. They are stored in the liver and adipose tissue, and the absorption is dependent on the bile emulsification plus pancreatic secretion plus intact area. So this translates to the diseases that is going to cause fat-soluble vitamin deficiency. First, cystic fibrosis. This is at the level of the pancreatic secretion. There is a clogging of pancreatic secretion, and celiac diseases. This interrupts the intact ileum. So either in celiac disease or cystic fibrosis or bile problems, we will have like fat-soluble vitamin deficiencies. The toxicities are more common than water-soluble because being accumulated inside of the fat, they are fat-soluble, so it's gonna have a much longer time at the body. The deficiency common in malabsorption syndrome, the mineral oil intake can interfere with absorption. So to recap, fat is a vitamin A, retinol, or retinoic acid. So it is famously known as it's gonna support your vision. So it is a visual pigment component and is very important for epithelial cell differentiation and immune function and antioxidants. This translates to the deficiency. So as long as it is important for your vision, so this deficiency is gonna cause night blindness and xerophthalmia and mitotic spots, which are white spots, and it is also essential for epithelial cell differentiation. So its deficiency is gonna cause hyperkeratosis, but its toxicity, it is toxic first, and it is teratogenic. You have to watch for the pregnant patients taking excessive vitamin A. It's teratogenic, and it's gonna increase the intracranial pressure and cause tumor cerebri and hypercalcemia. Next, vitamin D, cholecalciferol or ergocalciferol, ergocalciferol. This is related to either like it's from protein or fat source. So the function of vitamin D, of course, calcium and phosphate homeostasis, and consequently bone mineralization, also some immune modulation. So its deficiency is different regarding its the onset of the deficiency. If the onset of the deficiency while you are a child, it's gonna cause rickets. So while you are an adult, it's gonna cause osteomalacia and of course hypocalcemia. On the other hand, the toxicity is gonna cause hypercalcemia, nephrolithiasis, and the metastatic calcification. Vitamin A, very high yield to know that its main role is antioxidant, and is gonna it is important for membrane protection and RBC stability. So its deficiency is gonna cause hemolytic anemia, of course, vitamin A deficiency and hemolytic anemia, of course, peripheral neuropathy. So B6 and vitamin A are very important for the nerves. So the deficiency of both of them are gonna cause peripheral neuropathy and of course also spinocerebellar ataxia. It's relatively non-toxic, may increase the bleeding risk. So vitamin K. So vitamin K, as we've talked about it before, it's a cofactor for gamma carboxylation of 2, 7, 9, and 10, and then activates protein C and S. So it's a deficiency, the carboxylation is not gonna proceed, and we will have like bleeding diastasis, increased BT and slash INR. This is common in the newborn. We have like sterile gut flora, where the toxicity is rare from it. So next is the water-soluble vitamins. They are like easily excreted in the urine except B12 and the folate. So regarding B12 and the folate, they are very important for DNA replication. But B12 is stored in the liver for 3 to 4 years, and the folate 3 to 4 months. So if you are asked about in the vignette and there is a like protein malnutrition or alcoholic for 3 to 4 months, this is not an sufficient time to have B12 deficiency, but it is a sufficient time to have folate deficiency. So B complex deficiencies in general lead to dermatitis, affect the skin, affect the tongue, and cause diarrhea, very high yield. So these are like the general scheme. They function as a coenzymes. So they have limited storage in the body, unlike the fat-soluble vitamins, they have high storage in the body, high capacity for storage, and they can cause toxicities. So to go fast, so vitamin B1 is thiamine, the active form is thiamine pyrophosphate. So it's important for decarboxylation reaction and the transketolase in the pentose phosphate pathway. So it's a deficiency. Maybe have like Wernicke-Korsakoff syndrome. We've talked about it, and the dry beriberi and wet beriberi. So dry beriberi is like peripheral neuropathy, while wet beriberi is an heart failure. B2 and B3. So B2 riboflavin and B3 niacin. So B2 is a fat and B3 is the NAD. So remember, we've talked about it. They are rule in the redox reaction and electron transport chain. And if we got B3 deficiency, also we've talked about the 3Ds, dermatitis, dementia, and the death and the diarrhea. And B12, B2 is very famous by causing angular cheilitis, like cheilitis at like side of your mouth and also at your tongue, glossitis, seborrheic dermatitis. B6, remember, B6 is very important for your nerves, and the deficiency is gonna cause peripheral neuropathy. Of course, B6 deficiency, microcytic anemia, and seizures. So it's important for the nerve. It is important for the nerve, and the deficiency is gonna cause peripheral neuropathy and seizures, and also microcytic anemia. So the active form is pyridoxal phosphate. Is important for transamination and amino acid metabolism in general. B9 and B12, B9 tetrahydrofolate, B12 methylcobalamin. So they are the B9 is important for one carbon transfer and purine and pyrimidine synthesis. So both B9 and B12 deficiency is gonna cause megaloblastic anemia, but B12 additionally is gonna cause subacute combined degeneration and increase homocysteine and methylmalonic acid, because B12 is a cofactor for methylmalonic CoA mutase and methionine synthase. Next is ascorbic acid. So the active form is ascorbic acid. So it's important for collagen synthesis, hydroxylation, also antioxidants, and iron absorption. So the deficiency is curvae, bleeding gums, poor wound healing. The DNA structure and organization. The DNA has double helix structure. So this means it has two complementary strands. One is running from 5' to 3', and the complementary strand is run at the opposite direction from 3' to 5'. Next is there is nucleotides that form the DNA. So the nucleotides are composed of deoxyribose sugar, phosphate group, and one of the nitrogenous bases, either A, T, G, and C. So adenine, cytosine, guanine, and thymine. So the adenine and the thymine are bonded together, while the cytosine and the guanine are bonded together. So A, T, and C and G. And the adenine and the thymine are bonded by 2 bonds versus the C and G, cytosine and the guanine, they are bonded by 3 bonds. So this translates to a different melting temperature. So the more there is an increase in the CG, which has 3 hydrogen bonds, the more the DNA melting temperature. So the CG content determines the DNA melting temperature, and the more we have CG bonds, the more we have a higher melting temperature for our DNA. Next is a chromatin structure. The DNA is very long and can't fit into the nucleus unless it has a special 3D structure. So the DNA is wrapped around histone octamers, and then we have like free DNA that is running, and then again DNA being wrapped around histone octamers, and so on. Free DNAs and DNA being wrapped around histone octamers. So this it's called the nucleosomes, and we have nucleosomes and the free DNA, and the whole structure is called the chromatin. So the chromatin is formed from DNA being wrapped around histone octamers, forming nucleosomes. So this is the chromatin. Next, the chromatin is further subdivided into euchromatin versus heterochromatin. So euchromatin is less condensed and it's transcriptionally active. So at the nucleus, we have like areas of heterochromatin and areas of euchromatin. The more we have euchromatin, the more the cell is means that the cell is transcriptionally active. By transcriptionally active, we mean it forms more RNA out of DNA. So the RNA being formed out of DNA is called the transcription versus the translation, which means the formation of proteins out of RNA. So euchromatin less condensed, more transcriptionally active versus the heterochromatin highly condensed upon each other and transcriptionally inactive. And next is the DNA replication basics. So we have some concept. The DNA replication is semi-conservative. What we mean by this, these are like the parent strands. This is a parent strand and this other parent strand, and it is divided by an enzyme called helicase. And this is a complementary strand and also a new complementary strand. So each DNA daughter has one from the parent and one complementary strand. So it is semi-conservative by this way. It has each daughter DNA molecules contains one parental strand and one newly synthesized strand. Next is the direction. The DNA synthesis occurs from 5' to 3' direction. So we have two strands, one running from 5' to 3', the complementary strand running from 3' to 5'. So first, the strain of events starts with the enzyme topoisomerase, which breaks the outer bonds to make our smooth strands. For the helicase enzyme to cut it into two halves, two parents like strands, separate strands, and the DNA binding proteins, the single-stranded binding proteins. Its function is to prevent re-annealing. So after the helicase has done its job and like separated the parent strand into two strands, we have the single-strand binding proteins. These proteins prevent the DNA from re-annealing again. Next is that we have our main enzyme, which is the DNA polymerase. We have two enzymes. The first, DNA polymerase 3 and the DNA polymerase 1. The DNA polymerase 3 is the main replicative enzyme and elongates the leading strand and the lagging strand fragments. So this is the main enzyme. So this is the main enzyme. It has a special direction from 5' to 3'. So it acts continuously when it complements the 3' to 5' strand. So this strand is from 3' to 5', and the complementary strand is from 5' to 3'. This is why the DNA polymerase 3 here acts continuously versus the other side that is supposed to be formed from 3' to 5', and the DNA polymerase 3 can't do that. So it has to form it discontinuously. It forms something called Okazaki fragments, and the Okazaki fragments is bonded by an enzyme called the DNA ligase that is gonna bond Okazaki fragments together to so we have one smooth continuous complementary strand. Next, you have to know that the DNA polymerase 3 can't start from scratch. It has to build on something. So it has to start building on something called RNA primer. So there is an enzyme called primase. The enzyme primase is the one that's supposed to form RNA primer, and the DNA polymerase 3 acts upon this RNA primer to form shorter Okazaki fragments at this strand and form one continuous DNA complementary strand on the other side. So here again, also it has to work on RNA primer. So after forming the RNA primer, we had to replace RNA primer by DNA. So this is the function of other DNA polymerase, which is DNA polymerase 1. So we have two DNA polymerases. The DNA polymerase 3 is the main replicative enzyme. That is the one that is doing the whole job. So, and the DNA polymerase 1 has a minor role, which is the removal of RNA primers and replacing it with DNA. So this is the DNA polymerase 1 that has minor role versus the DNA polymerase 3, which has the main role here. So the DNA polymerase 3 forms the complementary strands, and then they are like ligated by DNA ligase. So by this way, we're gonna form like two daughter strands. Next, the replication fork, which is a Y-shaped region, again, where DNA strands separate and the replication occurs. And this is the function of the enzyme helicase that is going to act as the replication fork to separate the two strands of our parent DNA. The leading strand is synthesized continuously, while the lagging strand is synthesized discontinuously as Okazaki fragments. The origin of replication is a specific DNA sequence where replication begins, which is a single, it is single in prokaryocytes and multiple in eukaryocytes. So we have to have like multiple origin of replication, and the DNA replication occurring at like multiple areas simultaneously. So we have like a very fast replication. This is true for eukaryocytes, which have like which are more complex, and the origin of replication is single for prokaryocytes. And there is something called AT-rich sequence. It is found in promoters and the origin of replication. So remember, the AT has two hydrogen bonds, so it is easy to be broken. So by this way, this is why it is acts as the promoter regions and the origin of replication, such as Tata box regions. So this is due to like being easily broken compared to areas where the CG content with three hydrogen bonds versus AT areas with two hydrogen bonds more easily to be broken. So again, we're gonna go through the enzyme helicase. This unwinds DNA template at replication fork, and the primase creates RNA primers to initiate DNA synthesis. So this is a primase initiate. So for the Okazaki fragments, it acts on multiple sites. So forms the beginning of each Okazaki fragments. But here on the other side, we have one RNA primer. So this is the enzyme primase that is gonna create RNA primers. DNA polymerase 3 is the main replicative enzyme, elongates the leading strand and the lagging strand fragments from 5' to 3', while the DNA polymerase 1 removes RNA primers and replaces it with DNA. The enzyme ligase joins Okazaki fragments by creating phosphodiester bonds between different Okazaki fragments. Topoisomerase acts like on the outside of the whole structure to smooth the and like make the strand ready for the helicase to like do its job. So the topoisomerase relieves the supercoiling by creating temporary breaks in the DNA strand, and the telomerase adds some DNA tags, TTA3Gs, to the 3' end of the chromosome. So with each replication, we may lose some segments. So the enzyme telomerase adds the tag sequence to the 3' end. So instead of losing our DNA, we're gonna lose some nucleotides from this tag sequence. By this way, we're gonna preserve the DNA. So the telomerase enzyme adds DNA tag sequence to the 3' end in eukaryocytes. The DNA polymerase has 5' 3' synthesis and 3' 5' proofreading exonuclease activity. What does this mean? We remember we have talked about how the DNA polymerase is the main enzyme is gonna form the complementary step from 5' to 3'. But what if we have some base pairing wrong? We it added a wrong base pair, so it is gonna act at a reverse direction to remove this base pair by something called the 3' 5' proofreading. So it's gonna proofread and do some exonuclease activities, gonna remove it. So it has 5' 3' synthesis function and 3' to 5' proofreading exonuclease activity. So the telomerase is upregulated in cancer cells and the progenitor cells. So this is the enzyme that is gonna keep our DNA from being lost. It is downregulated in aging and progeria. So we have some drugs such as etoposide and betinubicide. They are inhibit eukaryotic topoisomerase 2. Irinotecan, topotecan inhibit topoisomerase 1. Remember, topoisomerase, an important enzyme, is gonna remove supercoiling and break external bonds for the helicase to start. So this is an essential enzyme for the replication. So if we're gonna inhibit it, we're gonna halt the cell progression. So we what this equivalent to being a chemotherapeutic agent. So the hallmark of chemotherapeutic agent is halting cell progression and stopping the division. So if we're gonna inhibit topoisomerase 2 by etoposide, teneboside, or irinotecan, topotecan inhibiting topoisomerase 1, this is the way for chemotherapeutic agent to do its job. Next is the Bloom syndrome. The Bloom syndrome is caused by a deficiency in a helicase. So the helicase also has an important enzyme. So if we've got deficiency in it, we have some condition called the Bloom syndrome, which has BLM gene mutation. The DNA repair mechanisms. So there are different mechanisms for DNA repair, either nucleotide excision repair or base excision, mismatch repair, non-homologous end joining, and homologous recombination. Nucleotide excision repairs means removing bulky helix distorting lesions, so such as pyrimidine dimers from UV lights. So we have some bulky helix distorting regions. So for example, here, these are the UV light forming something called thymine dimers. So we have thymine dimers here, we're gonna remove it. So there is an enzyme called the nuclease that is gonna cut it here and cut here, and the helicase is gonna remove the damaged section and the DNA polymerase 1 and the DNA ligase makes the repair. Remember, DNA polymerase 1 was the one that removed the primers and formed DNA instead of it. It has another rule here, which is the repair rule. So we have these pyrimidine dimers, and the nuclease is gonna cut far away, some base pairs far away, and the helicase is gonna remove the damaged section, and the DNA polymerase 1 and the DNA ligase is gonna make the complementary strand and ligate it. So this is the way we're gonna remove bulky helix restored ingredients such as pyrimidine dimers from UV light. And this is defective in xeroderma pigmentosum. Remember, the people with xeroderma pigmentosum can't stand UV lights or the sunlight because if you look at the starting trigger for this chain of event is the UV light. So the UV light is the one that formed thymine dimers, and that is like the one responsible for this error. So this is the nucleotide excision repair. Next is the base excision repair. Removes the single damaged bases. So instead of removing bulky helix distorting lesions such as nucleotide excision repair, so the base excision repair is different. It removes the single damaged bases. So it involves glycosylase that creates abiurinic apyrimidinic sites. So abiurinic apyrimidinic sites, we're gonna act at the level of the bases of cells. So we're gonna remove the purines and the pyrimidine bases. So this is another level of repair. And then the mismatch repair. So the mismatch repair is the way we're gonna correct mismatched nucleotides in the newly synthesized DNA. And this is defective in the condition such as Lynch syndrome, which has another name called hereditary non-polyposis colorectal cancer. So hereditary non-polyposis colorectal cancer, aka Lynch syndrome, has defect at the level of mismatch repair. So this is supposed to correct mismatched nucleotides in the newly synthesized DNA. So it detects and corrects this slipped strand mispairing or the mismatched nucleotides. So this if affected is we have Lynch syndrome. Non-homologous end joining versus homologous recombination. Non-homologous end joining reverse double-stranded breaks without requiring homology may result in loss of genetic information. This is defective in ataxia telangiectasia. So this is non-homologous end joining. We don't build upon another strand. It just repairs randomly, repair double-stranded breaks, doesn't require homology, may result in loss of genetic information, but it is gonna seal the break. So its main function is gonna seal the break. If we have defect in non-homologous end joining, we are proposed to ataxia telangiectasia versus homologous recombinations that uses a homologous DNA as a template for accurate repair. So non-homologous end joining is gonna seal the gap and may result in loss of genetic information, but homologous recombination uses homologous DNA template for accurate repair. This is defective in a BRCA1, BRCA2 mutation, breast and ovarian cancer, and also in Fanconi anemia. So you have to remember with which goes with which. So the nucleotide excision repair removes the bulky helix distorting region and is defective in xeroderma pigmentosa, where the defect at the base excision level removes the single damaged bases. And the mismatch repair, you have to memorize this associated with Lynch syndrome, hereditary non-polyposis colorectal cancer, mismatch repair defect. Non-homologous end joining goes with ataxia telangiectasia versus homologous recombination defect is with BRCA1, BRCA2, and Fanconi anemia. So BRCA1, BRCA2, Fanconi anemia, defective homologous recombination, non-homologous end joining ataxia telangiectasia, nucleotide excision repair, xeroderma pigmentosum, mismatch repair, Lynch syndrome. These are very high yield things to memorize. And the DNA mutation and the consequence, there are maybe silent mutations, missense, nonsense, frame shift, split size mutation, kind of DNA mutation and its consequences. So the mutation may be silent. So there are 3 codons, first, second, and the third codon. So each combination of the 3 codons doesn't necessarily code for a different amino acids. They are amino acids can be produced by many different combination of codons. So if we got an error that is gonna give same amino acid, so this error is gonna pass silently. So this what we mean by silent mutation. So this codes for the same amino acids. This often occurs in the third codon position. So if we got defect in the third codon position, we may end with the code for the same amino acid, and there is no change in the protein, and everything is very good here. So this is the silent mutation. Next is the missense mutation. So the missense mutation means we've got a different amino acid. So the famous example for the missense mutation is glutamic acid being transformed into valine. So in the beta globulin of the hemoglobin, we got glutamic acid normally. If it is converted into valine by having a missense mutation, and the difference in the codon resulted in a different amino acids, we will have sickle cell disease. This is an example of missense mutations. Next is the nonsense mutation. So the nonsense mutation is the creation of premature stop codon. So why this is like nonsense? It the different codon, the error that resulted in the different codon didn't produce another amino acid such as in the missense mutation, but instead it produced the premature stop codon. So this is why it is nonsense. It doesn't produce another amino acid. It produced a codon that is gonna stop protein synthesis. So it creates, so instead of having nonsense mutation, instead of creating a different amino acid, it creates another thing, which is a premature stop codon that is gonna stop translation. So UGA, UAG, and UAA. So UGA and the opposite of it, which is UAG and UAA. So remember that results in truncated over non-functioning proteins such as Duchenne muscle dystrophy, some forms of Duchenne muscle dystrophy. So the silent mutation, no example because it doesn't do anything. Missense mutation, the famous example of sickle cell disease. Nonsense mutation, some forms of Duchenne muscle dystrophy, and our truncated non-functioning protein due to UGA, UAG, UAA. Next, frame shift mutation. So insertion or deletion of nucleotides not divisible by 3 is gonna be a very, very bad problem because each, remember, there are like 3 codons for each amino acid. So if we for example, add 3 codons, it's gonna shift the process and we will have the same sequence of the consequent amino acid. But let's suppose we have insertion or deletion of nucleotides not divisible by 3. So this is gonna affect the whole consequent chain of amino acids. So this is gonna alter reading frame of all downstream codons. Example: Duchenne muscular dystrophy, Tay-Sachs disease, cystic fibrosis. So remember there are some forms of Duchenne muscular atrophy resulted from nonsense mutation, others resulting from frame shift mutation, and Tay-Sachs disease and cystic fibrosis. Another example so that involves frame shift mutation. Spliced mutation affects intersplicing, often retaining introns in mRNA. Remember, mRNA has introns and exons. So if it retains introns, so this is an example of a splice site mutation, such as beta thalassemia. The beta thalassemia sometimes called by splice site mutations. So the degree of functional mutation, so the silent is the least affected. Next is the missense mutation. That's gonna produce another amino acid such as sickle cell disease. Next, nonsense mutation is gonna cause truncated form of protein such as Duchenne muscle atrophy. And the next is a frame shift mutation, the most dangerous because it affects the all consequently synthesized amino acids. So examples: Duchenne muscular dystrophy, Tay-Sachs disease, and cystic fibrosis. So the Duchenne muscular dystrophy again can be caused by nonsense or frame shift mutation, while Becker muscular dystrophy caused by some other thing called in-frame deletions. Next is different kinds of RNA polymerases. So we have RNA polymerase 1, RNA polymerase 2, and RNA polymerase 3. So we have 3 different RNAs: rRNA, mRNA, tRNA, and the 5S rRNA. So the RNA polymerase 1 is gonna synthesize ribosomal RNA, rRNA. 2 is gonna synthesize the messenger RNA, mRNA. 3 is gonna synthesize the tRNA or transfer RNA, and the 5S rRNA. So the location, the RNA polymerase 1 is located in the nucleoli. So the ribosomal RNA synthesized in the nucleoli. So this is the most central. So RNA polymerase 1, ribosomal RNA, most central in the nucleoli, versus the RNA polymerase 2, messenger RNA, and the transfer RNA way out in the nucleoplasm. And the rRNA is the primary component of ribosome. So this is like the protein factory. The ribosome rRNA is the primary component, and the RNA polymerase 2 synthesizing rmRNA. So it binds to TATA box, TA box with transcription factors. So it is inhibited by alpha amantine in this cab mushrooms. So it's like you have to know this example that alpha amantine in this cab mushroom is the one that is gonna inhibit RNA polymerase 2, and the RNA polymerase 3 is the one that's gonna synthesize the tRNA and the 5S RNA located in the nucleoplasm. tRNA delivers amino acids during the formation of the protein. Is the our like transporting vehicle is the tRNA. So the different types of RNA polymerases, the RNA polymerase 1, RNA2, polymerase 2, and 3. So the RNA polymerase 1 is the one that is going to synthesize ribosomal RNA. So we have ribosomal RNA, messenger RNA, tRNA, and the 5SR RNA. The RNA polymerase 1 is the one responsible for ribosomal RNA synthesis. 2, messenger RNA. 3, transfer RNA, and the 5SR RNA. So the location, RNA polymerase 1 located in the nuclei. This is the most central in the nucleoli, while 2 and 3 located in the nucleoplasm. And the RNA polymerase 1 synthesizing RNA, so the ribosomal RNA is like the factory for like proteins, so it's the primary component of ribosomes, versus RNA polymerase 2 forming mRNA, so the mRNA. There is RNA polymerase 2 plus transcription factors binding to data box within the promoter sequence. Now, if the data box is mutated, so this is gonna mean the decreased binding of RNA polymerase. So this is the function of RNA polymerase 2, and it's like rule of synthesized messenger RNA. It is inhibited by alpha amantine in this cab mushroom. So the alpha amantine is gonna inhibit RNA polymerase 2 versus RNA polymerase C, which is responsible for the synthesis of the transfer RNA. This is like the vehicle that delivers amino acids during the translation. So the ribosome is the main factory, and the tRNA or transporter RNA is like the vehicle that is gonna deliver amino acids for translation, aka protein synthesis. So the mRNA processing in eukaryocytes, so the initial transcript of mRNA called heterogeneous nuclear RNA. So this is like the initial transcript, and it has to be acted upon. So first there is addition of 5-methylguanosine cap. So at the 5- end, we will add 5-methylguanosine cap. On the 3- end, we gonna add poly A tail. So this, of course, it was a heterogeneous nuclear RNA, which is like the initial transcript. Then we're gonna splice introns. So it's gonna splice and remove introns, and we're gonna export the mature mRNA to the cytosol for translation. So all of this mRNA processing occurs like in the nucleus before being transported into the cytosol. First, addition of 5-methylguanosine cap and 3- poly A tail and splicing of introns, and extrusion into the cytosol for translation. So this is the RNA polymerase. So binding at a data box. So this refers to RNA polymerase. So RNA polymerase that is gonna form this RNA from DNA, and these are the deoxynucleotides. Then this is the enzyme RNA polymerase, and this is a DNA RNA hybrid. This is RNA being formed out of the DNA. Here, this is the direction of polymerization, and this is the coding strand. And of course, there is unwinding of DNA. So the regulation of gene expressions. So we have some regulatory elements as the promoters, the enhancer, silencer, DNA methylation, and the histone modification. The promoters, they are like the sites where RNA polymerase 2 and the transcription factors behind it. Remember, RNA polymerase 2 is the one that is responsible for forming messenger RNA. Remember, it binds at some like sequence called data box or cat box, aka the segments containing AT-rich sequence. So the promoters are located upstream from gene locus. So it doesn't mean it like at the start of gene locus, it occurs upstream of it. So this is the promoters, the site with AT-rich sequence, the sequence with 2 hydrogen bonds that is easy to break and to start replication from this sequence. So this is are the promoter regions upstream from the gene locus, the site for RNA polymerase 2 and the transcription factors to act. Next is the enhancer. So these are the DNA regions that upregulate gene transcription. So can be located far from the genes they regulate and bound by activator proteins. So these are like enhancers. So they are maybe very distal to the regions that is gonna enhance, not need to be near. So they upregulate gene transcription. They bound by activator protein. So These are like the activator proteins. So these are the activator proteins that is gonna bind to enhancer region. So first you have to know they may be like far away. Next is they are bound by activator proteins that's gonna affect like maybe distant gene regions and enhance their like transcription. And the silencers, they are like DNA segments that downregulate, on the other hand, gene transcription. They are bound by repressor proteins. So the enhancer are bound by activator proteins versus the silencers that are bound by repressor proteins. The DNA methylation means the addition of methyl groups to DNA, typically as a CBG island. They generally replace gene transcription. So this refers to like epigenetics. This is a field where there are like control of the genes without changing its sequence through methylation or acetylation. So the DNA methylation generally represses gene transcription. We don't like change the sequence, but we had methyl groups typically as a CBG islands. So this involves genomic imprinting and X-chrome inactivation. So this switches on and off without changing the gene sequence, and histone modification. So the histone, remember, the chromatin had like histones and the DNA wrapped around it. So by this way, by manipulating the histone, we're gonna like control the proliferation of the cells and the replication. So the acetylation relaxes the DNA coiling and increases transcription, which is the formation of like RNA. And the deacetylation tightens the DNA coiling. So the deacetylation is activatory, so relaxing and making the transcription increase, while deacetylation tightens coiling and it's inhibitory. It's gonna decrease transcription. Methylation, of course, is gonna suppress transcription. Remember DNA methylation or methylation of histone. Any methylation here is gonna suppress transcription versus acetylation, which is activatory. So it's gonna activate it by relaxing the DNA coiling. So they remember euchromatin transcriptionally active, less condensed. So we have increased the histone acetylation. Remember, it's activatory versus the heterochromatin highly condensed, transcriptionally inactive, has increased the methylation with decreased acetylation. Enhancers can be located like hundreds or thousands of bases away from the genes they regulate, and like the dysregulated DNA methylation is implicated in fragile X chromosome syndrome. So this related to like switching on and off of expression. So this is related to fragile X syndrome. And altered histone acetylation may contribute to gene expression changes in Huntington disease. So you have to get a paper and like write every like syndrome and the change that is like related to it. So Huntington disease is related to the acetylation of histone versus like DNA methylation dysregulation is related to fragile X chromosome. So remember, here's this enhancers and like these like the activators that is gonna bind to enhancer and affect like areas that is gonna genes that may be 1,000 bases away from it. And this is a promoter, which is the area rich in T80 sequence. So the DNA polymerase and all the replication is gonna start from the promoter regions. The clinical application, xeroderma pigmentosum, remember, defect in the nucleotide excision repair related to UV. So the UV lights is the thing that is gonna like started the cascade of events. So the UV causes induced by pyrimidine dimers, and if we have got a defect in the nucleotide excision repair, we will have xeroderma pigmentosum. So the clinically will have extreme photosensitivity and early skin cancer, dry skin. Next, Lynch syndrome, defect in the mismatch repair genes MLH1, MSH2, MSH6. So this is related to microsatellite instability. So there is an increase in the risk of colorectal, endometrial, and other cancer. You have to memorize colorectal cancer and endometrial cancer and Lynch syndrome. And also the defect in the microsatellite instability. So the sickle cell disease, missense mutation, glutamic acid is transformed into valine in the beta globulin. So this results in abnormal hemoglobin S. So these patients will have vaso-occlusive crises, hemolytic anemia, and susceptibility to different kind of infection with special immunization schedules. So fluoroquinine toxicity. So the fluoroquinine mechanism of action is the inhibition of prokaryocyte topoisomerase 2. So remember, it's gonna inhibit like replication for these organisms. So this is the way it's gonna fight bacteria, but it may have like side effects by inhibiting the eukaryocyte cells. By this way, it's gonna cause tendonitis or tendon rupture by like killing our cells. So Achilles tendon rupture, very famous, famously associated with fluoroquinolone toxicity. So it cannot be taken with the divalent cations, calcium and iron. You have to watch for this if you are prescribing one of them. Comment with if you are prescribing one of them with fluoroquine alone. So DNA replication semi-conservative occurs from 5' to 3', Okazaki fragment joined by DNA ligase. They are stop codon UGA, UAG, and UAA. So these are the stop codon. And if we have like nonsense mutation, we're gonna get one of these, and we will have truncated protein. The alpha amantine like inhibits RNA polymerase 2. That this is the one that is responsible for our messenger RNA. So I hope you guys enjoyed our this episode, and see you in next episode to continue our high yield biochemistry revision. Thank you.